In the next section of this talk, we're going to look at causes in more detail. What is it that causes pressure sores and what predisposes a patient to developing pressure sores? Now obviously, ultimately, the causes, as we've said, are pressure and shearing forces. But let's look at a little more detail. Now sometimes people divide the causes into extrinsic and intrinsic causes. In this taxonomy, extrinsic would be causes from outside the patient, for example, pressure. Intrinsic would be things about the patient themselves that predisposes them to sore development. For example, other systemic infection, or maybe malnutrition, or tissue edema. So sometimes intrinsic and extrinsic factors are differentiated. So as we look through the list I've got here, you might want to decide which you think are intrinsic and which are extrinsic. But let's look at more detail now to try and help us in our realisation of risk and prevention of pressure sore formation. So, contributing factors towards pressure sore formation. And you remember we said that pressure sores are a combination of two things, pressure and time. Well, shearing as well, obviously. But remember, the longer that someone is in a particular position for, the longer someone is subject to a particular pressure for, the more likely it is they're going to develop a pressure sore. So any condition which causes immobilisation and lack of normal movement. Now normally we're moving around all the time. So for example, in a single night's sleep, someone might move 150 times. And when we're sitting in a chair, we keep moving our position in the chair. So we sit towards the left-hand side, and we sit towards the right-hand side. We sit forward, and we sit back. So we constantly move the pressure on different parts of the sitting or lying surface. So normally, without realising it, we're always shuffling around and relieving the pressure without thinking about it. But if a patient is unable to move, then the pressure is going to build up on one area. So for example, any patient that is unconscious clearly is going to be lying wherever they happen to be when they became unconscious. Many orthopaedic conditions, the patient's mobility is severely restricted. Sometimes pain might stop a patient from moving around. And then any condition which causes general debility is going to cause reduced mobilisation. So anyone who is immobilised or reduced mobilisation for whatever reason. Now a second reason is poor nutrition. All the cells of the body obviously need a good supply of nutrients. And if that supply of nutrients is reduced, in combination with pressure, then the two factors are going to potentiate each other. So any condition where there is poor nutrition, reducing the nutrition to the cells. And particularly in the case of poor nutrition, we can think about anemia. Because if a patient's anemic, whether it's iron deficiency anemia or pernicious anemia due to shortage of vitamin B12 or folic acid, then there's going to be a reduced oxygen carrying capacity of the blood. That means that if the blood supply to an area is reduced because of pressure anyway, and that blood in itself is not carrying much oxygen, then again that's going to exacerbate the localised tissue hypoxia. As well as that, any condition causing dehydration can reduce the volume of the blood and the amount of blood and the quality of the blood getting through to the tissues. So poor nutrition or poor hydration. Another factor is edema. Any patient that is edematous is more prone to developing pressure sores. So in edema, if you imagine that these are the cells of the body here, the cells of any tissue, in this case the tissue which is under some pressure or some shearing force. And normally, of course, there's adjacent capillaries. Now, when there's edema is fluid in the tissues. And when there's edema, there's excess fluid in the tissues. So there's more fluid here than there's supposed to be. And if there's more fluid there, I think you can see that that is going to have the effect of increasing the distance from the cells to the capillaries and from the capillaries to the cells. Therefore, in order for the cells to become oxygenated, the oxygen must diffuse over a greater distance because of the increased amount of tissue fluid, which is, in fact, the edema. Therefore, the cells will become hypoxic. So if there's any reduction in blood flow to the capillary as the result of pressure on the capillary, then it's going to reduce the blood supply to the capillary, reduce the amount of oxygen getting through, and in addition to that, there's going to be an increased distance, therefore reduced amounts of oxygen getting to the cells. So any tissue which is edematous is particularly prone to pressure sore development and must have the pressure relieved very regularly, or ideally have no pressure on it at all. Another factor, body weight. Well, body weight can go either way. Patients that are very thin, I think you can realise in thin patients there's less padding between the bone and the outside surface. So because thin people have little subcutaneous fat, so there's little subcutaneous fat to protect the bony prominences. Therefore, the tissue that is left is more exposed to the bone. Therefore, there's a greater amount of pressure. So thin people more prone to pressure sores because of reduced subcutaneous padding. And body weight is also a factor in patients that are overweight, because obviously the heavier the patient, the greater the amount of pressure being transmitted through to the surface on the pressure points. And often people that are obese have reduced mobility as well. And of course, as well as increased pressure in an obese individual, there's going to be increased shearing forces as well. So body weight which is too slight, body weight which is too great, both predisposing factors contributing to pressure sore formation. Let's now think about patients with reduced sensory or reduced motor ability, with sensory and motor deficits. Now, patients with sensory and motor deficits are prone to pressure sores, but sometimes it's not that. Sometimes it's an inability to interpret sensations that they receive. For example, they might know that they feel uncomfortable but don't quite know what to do about it. You get this in patients with dementia and patients in confusional states. So the mental state is an important predisposing factor to pressure sores as well as the physical state. But thinking about sensory deficits first of all, that someone with sensory loss, then they're not aware of pain and pressure because they can't feel it because they've got a sensory deficit, therefore they don't bother moving. And someone with motor deficit, well, they may be aware of pain and pressure but be unable to move. For example, patients with some spinal cord lesions, for example, when they're sitting, they can't move to relieve the pressure sometimes. So paralysis associated with muscle wasting, causing lack of movement. And as well as that, if there's muscle wasting, then that further reduces the padding between the skin and bone in people with motor deficits. So sensory and motor deficits, another predisposing factor. Another factor is vascular effects. Any disruption in the circulatory system is going to lower the patient's resistance to pressure sore formation. For example, in shock, when the blood pressure is low and the blood pressure is not adequate to perfuse all the tissues. Or in a patient with arterial disease, with atherosclerosis, or a patient with vascular damage due to smoking, particularly affecting the periphery. So any condition which lowers the perfusion pressure of the blood due to the fact that the blood pressure is low or the blood vessels are unable to carry the blood properly because they are diseased. So vascular factors. Shearing forces I think we've covered fairly well. It's when a patient slides down. But as well as when patients slide down the bed, you can also get shearing forces if nurses pull them up the bed using bad technique, if they're dragged up the bed, a so-called drag lift. So the shearing forces will occur when patients slide down, but also when nurses drag them up again if that's done badly. And this results in a loss of epidermal surface, as we've mentioned, and stretching of the surface tissues and blood vessels, and shearing on some deeper tissues. So, another factor, incontinence. So, if the linen's damp due to continuous moisture, this can lead to tissue damage in skin that's damp for a long period of time. And of course, this is often a problem in military circles when soldiers have to keep their boots on for days on end. They can get a condition called trench foot due to dampness. And as well as that, there's acids and alkalines and things in the urine and faeces that damage the epithelium. This can cause some chemical burning and inflammation of the surface of the skin. And this can lead to damage of the protective barrier function of the skin and breaking down of the sebum and things, and it's just a general insult to the skin. So incontinence, another predisposing factor. Clearly, patients that are incontinent should be kept should be kept clean from urinary and fecal contamination of the skin. As we've already mentioned, the mental state of the patient is important. For example, a depressed patient may be so apathetic that they can't be bothered moving or just don't see the point in moving. Of course, if the patient's confused or uncooperative for whatever reason. So the mental state of the patient, quite important in pressure sore formation. So motivate your patients to change position whenever possible. And of course, if they can't be motivated to change their position themselves, you need to do it for them. And of course, there's a whole host of medical conditions we could talk about which reduce the quality of the patient's tissues and make it more prone to pressure sores. We've already mentioned patients that might be comatose, but also patients that are diabetic, partly because the circulation is reduced and partly because the levels of sugar are high. You get glycosylated tissue. And any infection that does occur is the bacteria are well fed by the high glycemic levels, the high amounts of sugar in the blood. So type 1 or type 2 diabetes mellitus can be a predisposing factor. Patients on steroid therapy, again, steroids prevents proper wound healing. Patients on cytotoxic therapy, because the cytotoxics actually kill the body cells. Patients with respiratory conditions or dyspnea for whatever reason, because the amount of oxygen in the blood is reduced due to the respiratory condition. We've mentioned patients with anemia and also patients with fever. So many medical conditions which can also predispose to pressure sore development. We need to be aware of all these possible contributing factors and to make allowances for them if they are present.